Okay, good morning. Thank you everyone for joining us and welcome to our breakout session. It is my honor to introduce you to Dr. Angela Palmer-Wackerly and Dr. Virginia Chaidez. I hope I said that correctly.
You did.
Who will be presenting Community Health Workers, One Person Can Make a Difference. So over to you.
All right. Well, good morning and happy Friday, everyone. I'm Virginia Chaidez. I'm an assistant professor in the Nutrition and Health Sciences Department at UNL. And I'll let Angela introduce herself real quickly.
I'm Angela Palmer-Wackerly, and I'm also an assistant professor at UNL, but I'm in the Department of Communication Studies, and I specialize in health equity communication.
Okay, so we really want to make this presentation more of a very informal Friday. I've got jeans on. Please feel free to interrupt us at any time with questions, either in the chat, or we'll unmute you if you rather chime in verbally. We're happy to have dialogue, but I'm going to pull up my slides. So give me a sec here. Okay, so here we are. Let me minimize so I'm not looking at myself. Okay, so we just introduced ourselves. I gave a little bit of housekeeping, so we'll go ahead and jump in. If my computer will let me. Okay, first I just want to acknowledge, before we begin our presentation, I just wanted to pause and share the University of Nebraska's land acknowledgement statement, which openly acknowledges the legacies of more than 150 years of displacement, violence, settlement, and survival of the indigenous people of Nebraska. I really see this as a small step, but one that I hope will catalyze a movement for acknowledging truth, having honest conversations, as stated by yesterday's keynote speaker, Dr. Warren. Really, I see this as a beginning path to healing and really a necessary step to achieving health equity for indigenous people and beyond. Okay, so this is essentially an overview of what we'll cover today. So first, we're going to talk about really a chapter that Angela and I co-authored together that provides kind of this overview and framework on how we envision community health workers making a difference, at least from a researcher's perspective. And then we're going to talk about how our research has contributed to supporting community health worker workforce development. So giving you some concrete examples of what that looks like. And then lastly, and just as importantly, we really do want this to be a two-way conversation, to have a dialogue with you and get some feedback about future directions for our research. Okay, so for starters, we'll go into the overview and framework about how community health workers can and really already do make a difference. Angela, go ahead.
Okay, so we wanted to start with just basically looking at health equity, right? And so no doubt the majority of you are already, if not all of you, already familiar with this framework, but it really shows the progression of the focus from health disparities, which is really taking more of a deficit approach, which is really concentrating on the differences, right? Which are really important because we need to look at the differences in mortality, differences in disease burden, things like that. But then it starts shifting, right? From 2010 to 2020 is when we're really looking at achieving health equity, right? And this is when we're really looking at, so how do we improve the health of all groups? And so then that shifts to the more recent 2030 goal, which is we really want to eliminate the health disparities, achieve health equity, and attain health literacy to improve the health and well-being of all. And so by framing it in health equity as opposed to health disparities, which as you see, health disparities is still involved, an important piece of the puzzle that we're all trying to solve, health equity is really focusing on the goal. and that is the attainment of the highest level of health for all people. And we do this by valuing everyone equally. Now, this doesn't mean treating everyone equally, because therefore some perhaps communities need more resources than others because they're under-resourced, right? So this is where we're really harnessing our efforts to address avoidable inequalities, historical and contemporary injustices. I mean, it looks like we have a participant who raised their hand. Rahab, I'll go ahead. I've asked you, go ahead, I've allowed you to unmute if you'd like to jump in.
Oh,
Okay, go ahead.
Yeah, I'm sorry, just by mistake, sorry.
Oh, okay. Yeah, no worries. And we were excited that you were going to jump in. But if you do have a question, go ahead and feel free again to do that. Thank you so much. Okay. And so Virginia, we can go to the next slide.
All right, thanks. I wasn't sure if we cut you off or not. Okay, moving on. Okay, so many of you may already know who community health workers are, but for those of you who may still be new to this, I just want to cover all bases. So community health workers, at least by the American Public Health Associations, they have a really beautiful definition of community health workers, which is really defined as a frontline public health worker who is a trusted member of and or has a unusually close understanding of the community served. And this trusting relationship enables the worker to serve as a link or a liaison between the community and health services and or social services to really help facilitate access to those services and improve the quality and cultural competence of service delivery. So a community health worker, on top of that, also builds individual as well as community capacity by not only increasing health knowledge and self-sufficiency, but doing it through a range of activities, which include things like outreach, community education, informal counseling, social support, and advocacy. And so I often, when I talk about community health workers, I preface by saying community health workers is really kind of an umbrella term. And so a lot of these individuals can be known by a lot of different names, some of those listed here on the slide. And so in the context of health equity, I really think of community health workers are the people who bridge the underserved, the marginalized populations with those healthcare services. And so I just want to give you a little background on myself and how I came to really focusing on community health workers, particularly here in Nebraska. So I came to UNL January of 2015 is when I started my position as an assistant professor. And so my background is actually nutrition. I'm a registered dietitian by training. You know, I focused really heavily on obesity.
I'm sorry, Virginia.
That's okay.
My 7-year-old is sick and he is home with me today. I keep trying to mute and I apologize.
Oh, no worries. Hi, Luke. Okay, so I'm a registered dietitian by training. My training is in nutrition. My doctorate is in nutrition. And I really came to UNL with a focus on obesity prevention, particularly in Latino populations, since that population is disproportionately affected with chronic disease such as obesity. And so when I got to UNL, I kind of took a step back because I really wanted to think more about population-based strategies and addressing chronic disease in audiences such as Latinos. And so I also brought a lens of public health because I had done some postdoc work kind of exercising those epidemiology, big data analysis types of skills. And so that was helping me figure out my path, right? And so I found myself really now describing myself as a health disparities researcher. And so I had always really been interested in community health workers. They've been in the literature for a while. They've been in use for quite a while. And so when I got to UNL, I saw that as an opportunity to really kind of see where the gaps were. And certainly there were gaps, particularly in the literature. There was very little, if any, literature on community health worker perspectives in what we needed to do in terms of supporting them, training them, and really understanding what makes them so effective, right? We understand, that they can be effective with certain interventions, across an array of health conditions, but there's still so much we don't know about community health workers and why they are so good at what they do, and how we can better facilitate development of that workforce. So that's really where my jumping point was. And so these two images that you see on the screen here are two books that MHDI, the Minority Health Disparities Initiative, of which Angela and I are health disparities researchers in that network. We were involved in writing these short chapters for these books that were really meant to be summaries of the type of research that we're working on, in terms and in small chapters that key stakeholders across the state can easily pick up, read, and kind of get up to date on. And so both of these volumes, volume 1 and 2, the chapters that I had written provide some more background about the more recent history of community health workers here in Nebraska. And in fact, volume 2 is the chapter that Angela and I co-authored, and we'll talk a little bit more about that. But I also just want to put a plug in here that Angela and I actually still have at least a dozen free copies of this book. If anybody's interested and wants to, read more about the type of research that UNL researchers are working on, we'd be happy to send you a copy. We'll share our contact information at the end, so you can email either one of us or both of us and see who responds first. And we'd be happy to send that out to you. Okay. So I think, Ange, this is your slide.
Thank you so much, Virginia. And so like Virginia was explaining, right? So my evolution into this research area really came from, I specialize in health communication and specifically rural populations. And then when I came to UNL and I became affiliated with the Minority Health Disparities Initiative, a lot of the same questions I had around communication were really involving like doctor-patient communication, nurse-patient communication, things like that. And the more questions I was expressing to a community liaison at the time, Kim, she had said, you really need to meet Virginia. You both have similar questions, and I think your work would really complement each other well. So we've now been working together and collaborating for really about 6 years now, which is really exciting. So how our work really came together was through something called the ecological framework. And so this is a diagram model from Bronfenbrenner's work. And so it really shows the multiple levels of influence, whether that's communication or health behavior, and how these all really work to intersect and affect each other. So starting at the very center is the individual level. And this is the individual's attitudes, beliefs, personality traits. And then moving to the next layer, and this is sort of when you start to involve more people, you have the microsystem. And this is the immediate social environment, such as the family, the school, the church. And I really like to think about this as like small group communication or one-on-one communication. So these two levels are really where, at the time that Virginia and I started working together, these were really where the majority of my work, where it was placed. And it really focused on patient level decision-making and how communication from healthcare providers could really help patients make the best decisions for them. But then you move, we're going to get to the mesosystem last, and I'll explain why. But then you move to the exosystem. And this is really, again, you start to add more people. So your network is getting larger. And this is where you think of more like a community, right? So this can be your neighborhood, your larger institutions like UNL, organization, right? Where you're just involving much larger groups of people. But this also involves mass media, government policies, social services, and how all of these things work together. And then you move to the macro system. And this is really an individual's shared societal and cultural norms, values, and ideologies. So none of these are designed to be studied in and of themselves separately, but they all intersect. And Virginia's work really was centered at this time in the exosystem and macro system. So we really complemented each other's knowledge really well. And then where we really came together was the mesosystem, which is how all of these layers connect between themselves. And we realize this is really what community health workers are. They are really connecting the microsystems to the macro systems. And they do this, they are a key part of achieving health equity. And so this is really how we frame all of our work, focusing with community health workers.
All right.
And then the next slide. So this is just a more intuitive, simpler model of the social ecological model, where it shows these 5 layers: individual, interpersonal, organizational, community, public policy. So it's the one I tend to use in my classes because it's a little bit more intuitive than the Bronfenbrenner one. And this one is from the US Department of Health and Human Services. The CDC also uses this one. But then what we also like to really focus and this is our health equity work, is where we're really focusing on the social determinants of health and how all 5 of these major social determinants of health, healthcare, neighborhood, education, social and community context, which are things like the degree of social capital, social support, things like that. And then economic stability, right? Poverty, jobs, things like that. So all 5 of these are actually reflected through all 5 of these levels for social ecological model. We tend to think of them as only being reflected in the macro layers, like the community and public policy, but they're actually reflected throughout all of them. And so we really, in our work together, try to equally show how communication and health behavior are multi-layered, but then also really focusing on the social determinants of health.
All right.
Okay.
So we're gonna now switch gears a little bit to give you some concrete examples of some of the studies that we've actually published to understand how our research has contributed to informing community health workforce development. That is a mouthful. All right, so we'll go into more detail about studies that came out in 2018, 19, and 20. And I will start with the first study. So, first study in how it was published, not necessarily how it was happening in real life. Okay, so this particular study, the purpose, let me begin with the title. So it was the Community Health Worker Employer Survey, getting perspectives on community health worker workforce development in the Midwest. So the purpose of this study was really to capture existing employer perspectives or get a sense of the landscape in Nebraska for community health workers and to inform their workforce development. So I essentially took, in terms of methodology, I took a survey. I combined 2 surveys really. One was the first of its kind, Public Health Workforce Interests and Needs Survey. It was a national survey kind of assessing the public health workforce. I took that survey and I combined it with something that Douglas County Health Department had conducted to assess community health workers in their region, and essentially combine that to create a statewide survey. And so we mailed this survey out to about 500 employers across the state of Nebraska, trying to be really strategic about who we were targeting. That was beyond just the traditional healthcare settings that we think of, right? So I had different organizations that we targeted. So we oversampled schools because we figured principals were going to be really busy. And so we wanted to make sure we got enough of them responding. Lots of community-based organizations, local health departments, and even congregations, so faith-based organizations, as well as healthcare settings and others. And one of the things that we actually learned from Douglas County Health Department, again, working with partners, having these conversations, with their survey, they learned that it was really critical to identify a particular individual within an organization that would be in a supervisor role of the community health worker, or if it was an organization that didn't have community health workers, to potentially identify somebody who would be in a position to supervise a community health worker. So we were very deliberate about not only finding, an array of organizations to target, but a particular person within that organization. So that was really critical for us. And so we got a decent response rate. Out of the 500, nearly half actually responded and sent back in the surveys. And so some of the key things that we learned: one, I was really pleasantly surprised to find out that respondents favorably viewed their workplace as places they like to be, favorable work environments, despite the fact that nearly 2/3 of them actually typically worked over a 40-hour work week, right? So we had good workplace environments, so that was a plus. Another finding is that contrary to what we see in the literature, which suggests that a lot of community health worker positions are funded through grant funding, like a lot of it is temporary funding, right? In Nebraska, you did see a lot of that, but there was a combination of funding mechanisms. So it was not only government grant funds, but about 75% of respondents reported that they used general operating funds to employ their community health workers. So there's definitely a value that's seen in Nebraska in hiring and keeping community health workers around. So a mix of funding sources was another finding that we saw there. A third key finding is that even though in our sample, about a third of them, it was about 36% of our respondents actually employed community health workers, 51%, so at least half of them actually saw the need to hire or work with more community health workers. And so, I'm sorry, did somebody need? Okay, I was making sure somebody wasn't wanting to ask a question. Okay, and then the last of our key findings was related to an open-ended response to the question that we asked. Within the question that we asked was, in your organization, what needs could community health workers meet? And so we got about 165 respondents giving us some information about what they saw community health workers helping out with. And the largest number of respondents reported mental health issues as a priority. And keep in mind, this is pre-COVID. Okay, so you can imagine if mental health issues was the top cited needing to be met, you can imagine what that's like now. So other responses included connecting people with services or resources, educating the public on preventive health, family support, and home care and visitation types of things. Okay, so that was our study in 2018, and then subsequent study was lead authored by Angela. So I'll let her take it over.
And so another way that Virginia's and my work really complement each other is that both of us consider ourselves as mixed methods researchers, and we really value both quantitative and qualitative approaches. And so Virginia tends to specialize a little bit more in quantitative approaches with surveys, and then I tend to specialize a little bit more with qualitative and interviews. So this was an interview study. Virginia completed 28 interviews with community health workers across the state, and over one half of them were in Spanish. We wanted participants to be most comfortable in speaking whatever language they wanted to. And so we started with if we look at community health workers as being the meso layer that connects all of these layers in the social ecological model together, what are they doing communication-wise that is allowing them to do their jobs well, and where are they seeing barriers that people need to focus on? Because another gap we realized is that, sure, community health workers are involved in a lot of research studies, but rarely are their voices, number one, being the focus, and then number two, informing the policies that then create the work environments for community health workers. So we really wanted to centralize their voices as the experts in knowing what they need to do their jobs well. So the two key themes that we found that are focusing on the individual, interpersonal, and organizational layers, and we're in the process of now working on a paper for the community and more public policy macro layers. But the first three layers of the social ecological model, we found two key themes that cut across these three layers. And this was community health workers really desiring an increase in language accommodation, and we'll go into what that means, and then an increase in stabilization of how they are integrated into the healthcare network. Okay, so what this means is that for the first theme, which was increasing language accommodation, right? A lot of community health workers really talked about how they're really valued for their knowledge and their ability to communicate, not just language, but also cultural values, right? With the communities that they're wanting to connect to the healthcare system, right? But then sometimes they felt like they were part of an out group when it came to speaking to the healthcare providers, that they weren't treated as though they belonged in the healthcare system. So they really had these identity tensions. So for example, on the individual level, community health workers talked about, right, training is only offered in English. And so although I can speak English, I would also like it to be offered in Spanish, right? And they suggested things like interpreters, or they even referenced, when you think about in school environments, you have people who are able to have like phone assistants, for example, as they're working with English and Spanish. And they're saying, a lot of these medical terms are really complicated, so it would be really helpful if we could have Spanish accommodation as well in the individual level. But for the interpersonal level, they noticed that some of their patients did not want to use interpreters. And the reason for that was they were saying they desired privacy, right? So they were saying sometimes interpreters, even though they should be abiding by HIPAA, right, perhaps had passed along information to family members or other people in their social network out of concern for them, right? But patients also wanted to keep that information private, understandably. So there was a little bit of an identity tension there. So even when interpreters were sometimes available, patients didn't want to use them if they were too close to their personal network. And then organizational, perhaps of no surprise to anyone, was that there was largely a lack of interpreters available, right, for the patients that needed them. Either there were too many patients and only, let's say, one interpreter or none available, or things like a phone system, which just are not available, which are just not as helpful as having a community health worker. So then the second theme, which was increasing and stabilizing network integration, on the individual level, a lot of community health workers said, we'd really like the opportunity to specialize in our training. It's great to have general healthcare knowledge, but some of us would really like to have, like, let's say, certification in sexual health, or perhaps a degree in dietetics, right? Something that we could focus in our own individual area and be experts in that area. For interpersonal, they talked about how our state is diversifying in some of our communities and how difficult it is to be at the front lines of immigration and not being able to be culturally competent in how to communicate with all of these different groups. So sure, they might have been hired to communicate with Latinx populations, but now they're having to work with other groups of people who are coming in from other areas of the world. And so they're saying they really want to be able to offer that same type of accommodation to them that they're offering to their own patients. And then another thing that they talked about on the interpersonal level was that it's really hard for clients to trust them sometimes because there's not an official name recognition. So as we talked about, community health workers are known by many different things, right? Many different titles, but even the community health worker title doesn't always resonate with some of their clients. And they're saying we definitely don't like to use social worker because, well, number one, we're not that, but then number two, they really don't like that term. And so they said it's just really hard to be able to communicate what we do. And then some community health workers talked about privacy concerns. So where you saw with the increasing language accommodation, where some people didn't want to use interpreters or community health workers because they were part of the same community group. The same thing happened here, where when they were, let's say, going to do a sexual health workshop, right? They knew that some of the people in their community were uncomfortable because they're like, they don't want to come and talk about this with the same people they're going to see in the grocery store. So this particular community health worker hired another community health worker outside of the community to deliver that workshop, and that actually made the community members more comfortable. And then in the organizational level for this second theme, they really talked about sometimes there's a lack of respect from other healthcare providers. We're not appreciating all the knowledge that they bring, as well as not appreciating their cultural knowledge, but then also not integrating them, right? The CDC talks about integrating community health workers as key partners on par with healthcare providers, on par with patients, right? They're integral to that relationship and communication interaction. And they sometimes talked about how healthcare providers can dismiss them and not involve them to the level that they would like to be involved. And then, of course, much like we know from literature, is that definitely the issue of stable pay, and overwhelmingly people were working more hours than they wanted to. Okay.
All right. Thanks, Ange. Okay, so, and I just have to say, with what Angela just covered and having conducted those interviews with community health workers across the state, they have so much insight. It's incredible. I learned a lot, and I continue to learn a lot from them. Okay, so our third study was looking at, essentially, it took that first study I talked to you about, that sample of 240 some odd employers. It was a secondary data analysis using that data. And so our co-author, Kate Trout, who's now at Missouri State University, she wanted to look at the differences in how community health workers might be working in different settings and contexts, right? So looking more at exploring community health worker roles and determining whether there were any differences in how they practice in rural versus urban areas. And so because this was a secondary data analysis, she had to essentially work with a smaller sample, because we had to look at some community health workers were working in both settings. So we had to essentially only use those that were either working in one setting or the other to look at how those differences might play out. So this sample was about 97 employers. And so some key findings from this study were that, first, that employers with community health workers practicing in urban settings more frequently were funded from private funds. So about 40% versus their rural counterparts, which about 22% of them were utilizing private funds. Another key finding was that difference in employers were reflected in the types of work settings and populations that we saw. So, for example, there were significantly more schools that employed community health workers in rural settings, so about 31% of the sample, compared to urban settings, which is only about 13% of the sample. And employers with community health workers practicing in rural areas were more often working with adolescents, which makes sense, right? If they're working in if more schools are employing community health workers, it kind of makes sense that the type of population they'd be working with reflect that. So about 60% of the sample were working with adolescents in rural settings compared to urban settings, which is about 42%. We also saw that there were significantly more churches or faith-based organizations that employed community health workers that were practicing in urban settings compared to rural settings. And those community health workers practicing in urban areas worked more frequently with Black populations compared to their rural counterparts. So it's about 73% in urban settings versus about 36% in more rural settings. And then lastly, we really did not see any overall significant differences in the types of activities that community health workers were regularly performing between those organizations that employed them in urban and rural settings. So really in looking at these differences helps us understand what, if any, differences in how community health workers are being utilized for a strategic insight into how to, support and develop that workforce. So we know, for example, rural populations and healthcare providers face unique challenges because in rural settings, their populations tend to be older, they tend to be sicker, they tend to have higher rates of poverty, they are more likely to be uninsured, have less education, and are largely covered by federally designated physician shortage areas. So having a better understanding of what the landscape is like and what the need is essentially what we're trying to pull from this type of study. Okay, let me move on to the next slide, Angela.
Yeah, and so then this is a study that was created by the Minority Health Disparities Initiative, so MHDI, that both of us were co-investigators on. And so this is still probably to this day the most meaningful study that I have ever been a part of, and community health workers were integral to the success of this. And so this ended up being a photo voice study. And so for those of you who may or may not be familiar with that, that is where people share photos and they discuss them, and they discuss what's most meaningful to them. They usually have a question prompt that is provided by the researchers for that day. And it's usually created, the list of questions are usually created in concert with the community members. And so we had talked to the community health workers about which questions might be the best to use. And then they share photos that answer those questions, and then they decide and curate which photos are most meaningful to then create a community display. And so these photos were then displayed, I believe it was, I can't remember, 2018, I think, 2017, maybe fall of 2017 in Dawson County at the Historical Museum. And then I believe it was spring of 2018. Which was then at the Nebraska History Museum here in Lincoln. And it was really cool. So in Dawson County, we were reaching local policymakers, and then in the Lincoln one, Lincoln exhibit, we were reaching state legislators who then attended the reception to see the opening night of this exhibit at the museum. And so you can see here, so Malki Hussein, who is a community health worker, who was a community health worker at Lexington Regional Health Center. So you see her in both of these. She's talking in the left photo and then the center photo. And she's really sharing information to answer a question of where do you see people belonging and not belonging in your community. And so she was talking about how Somali women are really reticent to come in for prenatal healthcare because they're really worried that they're going to be recommended for a C-section, and surgery is really taboo in their culture. And so she was explaining how she and another community health worker, Sarah Ali, had created this workshop to really speak to their fears and validate them while also educating them on how prenatal healthcare could really help them and help their baby. So it was really interesting. And she also during this point talked about how, when you talk about miscarriage, like as a possibly negative side effect of not receiving prenatal care, she was like, the majority of people that is not a fear, because then they would just say Allah wills it. So it's not a fear. It's just a part of the natural cycle of, they just view it like, well, it'll happen if it's meant to happen. And if it doesn't happen, then that's the way that Allah wanted it. So it was really interesting to hear that perspective. And then on the right, we have Maria Reyes, who then was also a community health worker who was really integral to this project. And so she's showing how another person who then had to leave, so they couldn't share their photos. So she's sharing on their behalf. She was saying that they were really working to create a stop sign for this intersection that was really dangerous and near a daycare. And they were really worried about the safety of their kids. And you can see in the photo on the left, it was covered up. And so she was saying how they were trying to get that to be a stop sign again, that it was actually very needed, and they felt like the community wasn't listening to them. So they were talking about saying like they don't feel like their voices are as valued. So it was really interesting. And another interesting thing that happened from this study was that we originally had them meet as two separate groups, the Somali group and then the Latino group. And then what ended up happening was they actually wanted to meet together about midway through the 10 weeks. And so I came at their very first meeting. That's me in the center with the blue sweater. I came at their very first meeting where they came together. And it was so amazing to witness. Sometimes people were translating, sometimes they weren't, and yet we could still get the general gist of what people were saying through the photos, which is really, and through their nonverbal expression, which is also a really cool thing about photo voice and the power of photo voice. And so these are 3 articles then that have come through that project. One was led by Dr. Julie Tippins, and so it focused on emotional support and mental health among Somali men in a rural Midwestern town. And then we had the one in the center, which was really talking about, again, multi-level communication within this project and how we can improve it in the future. And so Maria and Sarah actually came on as co-authors. Malky wasn't able to at the time because she was too busy, but Maria and Sarah came on as co-authors to really invite their opinions into how we really need to improve in the future, what works really well, and then what could we work on moving forward in these types of projects. And then the third one was led by Virginia, and it was really looking at ethnic comparisons between health, happiness, hope, and then of course, social determinants of health again in Lexington. And again, we wanted to show this because this project really, again, that mesosystem was the community health workers, and they really said they wanted to be involved because number one, they were interested in it, but number two, they felt that it really affected their communities. And so they wanted to be part of linking all of these things together.
And I just want to stress again, Ange, was that the end of your spiel?
Yep.
Okay. So the 3 research studies that you see at the bottom of the screen, I just want to say again, those would have not happened had community health workers stepped in to actively recruit and encourage this vulnerable population that was really hesitant to come out and share their voice. This was right after the Trump election. Okay, so this would have not happened without community health workers. I just have to say that and stress that again. Okay.
Absolutely.
Okay, so now the fun stuff. We want to hear from you. So, but before we do that, I just want to share this slide briefly. These are just a few brainstorming types of ideas that we had going that we'll talk through. And so we're hoping you can give us some feedback on this, but also add to it or whatever. So the first is this idea of doing a more proactive, thorough community health worker workforce surveillance. And some of this effort has already actually started. In fact, Victoria Vinton, who's director of the Nebraska Action Coalition, she had kind of spearheaded this idea back in 2018. And so some of that work has started. Really where I was contributing to the conversation was to expand on doing a really robust workforce surveillance. Because right now, currently we know that anywhere from 320 to 680 community health workers are employed in the state of Nebraska. But these estimates, that's not a very clear estimate, right? That's a range, number one. Number two, those numbers don't necessarily, they do not include volunteer community health workers. So they're not even captured. Volunteer work is not captured at all in those numbers. And so those numbers are captured by Nebraska's Department of Labor. So they're the ones who actually collect this employment data in cooperation with the US Department of Labor. And that's how we get some of these estimates, right? But it's not thorough by any means. In fact, personal communication with the labor market information director at Nebraska's Department of Labor. I mean, they pretty much have said like they don't have the resources to conduct a more informative enumeration. And beyond that, I'm really interested in social network analysis, understanding, community health workers, they've got tentacles everywhere. And so understanding that their social networks, I think can be really valuable. Essentially, for this first bullet point, what I'm saying is that we need data that can provide a better estimate of the number of existing paid and non-paid community health workers in the existing workforce, as well as their existing networks, their training needs, their support needs, even identifying where their efforts are being focused on primary, more upstream types of activities versus secondary or more tertiary types of prevention activities. And just a better understanding of the collective understanding of the physical and mental health efforts that are being targeted by community health workers, particularly as in the context of health equity and reaching those populations that need to be reached, right? So that's the first kind of big idea, right? The second is centered around, providing community health worker support. And so we actually got a small funding from UNL's Extension's Reaching New Audiences grant. And really this is essentially asking the question, can a mindfulness intervention improve stress management and prevent burnout? So we are in the process of conducting a small pilot project to recruit community health workers to help us develop what a mindfulness intervention might look like for community health workers, with the idea of helping prevent burnout and manage the stress that they are dealing with in their day-to-day type of work. The third idea is really kind of really early brainstorming phases, again, focusing on community health workers' strengths. One of the things that I see community health workers being are essentially these empathic beings, right? They're incredibly in touch with their humanity and the willingness to want to help people, right? So I'm really curious, two things. Number one, to understand how that affective domain, that ability to connect with people on an emotional level, how that impacts health education and preventive health education types of efforts, right? Because I often teach my students in class, that there is this cognitive domain, right? We're teaching people content and knowledge. And there's also this psychomotor domain where you teach them these hands-on skills, but this affective domain, that emotional connection and being able to meet people where they're at, we don't know a whole lot about that. And I think community health workers can be a beautiful example of where we can study and learn better about that domain. The other idea I kind of am toying with is looking at doing some type of strengths-based assessment with community health workers to see kind of how they fall out and just to understand the profile of what a community health worker, what their strengths are, and to see if we can better align that with the types of roles that they might take on, right? Because as I mentioned earlier, their roles can be many, right? And so figuring out what their strengths are and seeing if we could do a better alignment with that, it's kind of another idea that I have out there. And then the fourth idea, I'll let Angela take away.
Yeah, so when Virginia and I come up with ideas where we're working together, as we talk about, we complement each other really well. And so the first three are really where Virginia's taking the lead, and I'm happy to help out wherever my expertise is helpful. And then in the fourth one is where I'm going to take the lead and open up, and Virginia is happy to help out where she can, and I would like anyone else as well who would want to be involved. But it's really through this work with Minority Health Disparities Initiative. And so I focus in rural populations, and then through the work with community health workers and also out in Lexington, really starting to focus on Black, Indigenous, people of color as well. And so we have another project going on right now with adolescents in Madison, Nebraska, focusing on sort of what's important to them when they think about their education, their future, their health, the stress they're dealing with, right? A lot of them are children of immigrants, and so really focusing on their stories. And so that combined in the last 6 years has really gotten me to think about, and in teaching my own health equity classes, where I tracked a lot of students who are BIPOC and rural and also want to go into some sort of healthcare career, there are a lot of barriers that prevent them from doing so. And I see it happen sometimes in college too, but they also talk about how it can happen in high school. And so really wanting to focus on creating and strengthening these pipeline development programs to really connect people from rural areas or people from under-resourced communities to really think about, if they do want to go into healthcare, what are ways that we can create stronger mentoring programs, right? A lot of times some of the research is talking about that parents, right, don't necessarily know all that is available. And so I can see it being a communication program intervention to aligning teachers, parents with the students, right? In addition to linking them to college more. And so this is something that I can see my work moving more and more with this.
All right. Okay, so I promise just a couple more slides, and then we really want to open this up. So I often, Angela and I often try to help people understand kind of this two-way relationship that, or conversation that's going on. So we as researchers, what we often say is, here are the things that we can offer. So we can offer new opportunities for solutions to old problems, right? Through research, trying to test things out. As well as access to knowledge about best practices and research methods. So essentially helping our community partners figure out what works the best to get the questions that you want answered, right, in terms of research methodology. As well as we can help with grant funding, right, to investigate these types of problems and provide incentives to research participants, right, to get them involved and help get the answers that you need. And then lastly, helping raise awareness, right, via these types of conferences, through publications, books, and even advocacy. Those are the types of things that we can offer. My arrow went away. Here we go. Okay. Whoops, sorry about that. Okay, and so what you offer, and we recognize this, is that you have the real world knowledge of day-to-day problems and context and nuance, right? You have a better sense of what's going to work and what won't work. We also acknowledge that you have access to the participants, right? That you want to help, and that we want to help, right? You also often have the deep community-specific knowledge that we as researchers need to know, right? So barriers that people might be facing with regard to health access. You also have a chance to educate us about your perspectives and those of the people you serve, and really anything else that you think others need to know, right? Particularly researchers. Okay. So.
And now we of course are happy to answer any questions that you have about our presentation, but then also we wanted to open it up to say that we're really open to any sort of comments, questions, feedback. It could be about this presentation. It could be about things we're not even thinking about related to community health workers and creating more workforce development. What challenges do you need help addressing? And then I love this question. Virginia always asks this for her research studies, and now I'm starting to do the same. You just get such rich, incredible answers. In an ideal world, what would you like to see for the future, right? And why shouldn't we be working toward that ideal world? And what has worked, has not worked in the past to solve these problems that you'd really like us to stay away from? So right now, we'd just like to open it up to you. And so feel free to speak to any of these or other questions, comments, anything that you have.